You can introduce yourself a little bit more too.
Yeah, well, let's see. First of all, how do I share my screen?
So if you go to the bottom, there's a share screen, green share screen button.
Got it. Sweet. All right, can everybody see my screen?
Yeah, looks good.
All right, well, first of all, my name's John Snyder. I'm a physical therapist here in Columbus, Ohio. I went to the University of Pittsburgh, so I had the pleasure of learning all about the knee from Rick. So it's good to see you again, Rick. So my primary focus in clinical practice is the treatment of individuals with hip and groin pain. I primarily work with ice hockey athletes and what we would consider fitness athletes. So anything from powerlifting to CrossFit is definitely something that I see on a regular basis. But what we're going to do today is kind of go through the literature in regard to the success of return to sport in individuals with FAI after hip arthroscopy, and then what kinds of special tests I tend to use on a regular basis in order to try to determine when somebody is ready to get back to sport. So we're going to start off by just talking a little bit about how successful we are at returning these athletes to sport. So this was a relatively recent systematic review looking at just general return to sport numbers. And they found that the general return to sport was around 85%, and it encompasses 80 to about 89% of that and 95% confidence interval. So pretty good return to sport numbers when you look at it on the basis of the yes or no criteria. The challenge here is the vast majority of studies that were included or studies that are currently available to us don't necessarily give return to sport data for us. So that complicates the interpretation of how well these athletes actually get back to sport. And then when we continue to look at what's available, this was a nice study performed by Riemann and colleagues, and it was over about 1,600 athletes. And it showed a decent amount of the ability to return to the same competitive level. However, when we look at the literature available to us, only 37% of these studies reported a pre-injury level of competition, and only 14% reported pre-surgery and post-surgery athletic performance. So this complicates our ability to extrapolate this number to the vast majority of the patients that we see on a regular basis. Look at how well we are able to get these patients back to normal. We're good at getting them better. As we look at the literature or the numbers in this individual study, we're good at improving their function. We're good at improving their ability to perform their ADLs, their symptoms improve. But when you look at the final scores after a year standpoint, these individuals still are not getting through the 80 to 100% in the HAGOS, which is a self-report questionnaire looking at a variety of different factors, in the modified Heritage Hip score. So when you look at the sport criteria, we aren't approaching 80% of normal, which is something that is very important when we try to get these athletes back to sport. So while we're improving their symptoms, we're not necessarily getting them back to normal. We're back to what they want to be in order to perform their sports. And when we continue to look at how typically in the literature is yes or no. Did this athlete return to sport or did they not? And when we break it down into smaller chunks, so did they return to the same sport at the same performance level? Did they return to the same sport at a lower performance, a different sport, or just generally the same sport, or if they returned to any sport? And when you look at this study performed by Warner and colleagues, as you return them to the same sport with the same performance, obviously the patient satisfaction skyrockets. But when you look at just the general, did you return to sport or not? While that number is higher, the patient satisfaction is much lower because it encompasses all those different patients that maybe they return to a different sport, or maybe they return to that same sport, but at a much lower level. So we have to take all these things into consideration because when looking at this, less than 50% reported satisfaction with their current return to sport level greater than 6 months after their surgery. And when we continue to look at what's available, it's kind of consistent in the literature. So this is a great study performed very recently of almost 200 athletes, and they found that only 17% returned to optimal sports performance. And of that, 42.9% did not return to the pre-injury level. So that is very concerning when we're trying to figure out how well these patients do after surgery and what we can recommend for those that are maybe not improving in the conservative care, and whether or not surgery would be beneficial for them to move further down the road. And when they continue to look at the information related to this individual cohort, of those that failed to return to pre-injury sport at that pre-injury level, 43% were not engaged in any sport due to their hip or groin pain. 32% were participating in another sport due to that pain. And there was a chunk that they didn't return to their sport for an unrelated reason. So it could be that maybe their career was over, maybe they lost interest in their sport. So there was a subset of patients that it wasn't directly because of their hip and groin pain. Now, when we look at those athletes that are engaged in that pre-injury sport at that pre-injury level, we then have to kind of look at how well they're performing at that level. So about 30% of these patients or athletes reported having optimal sports performance, including full participation. But on the reverse end of that, almost 50% had impaired sports performance or impaired sports participation, including restricted participation in that sport. So they were returning to that sport at their pre-injury level, but they weren't able to participate as consistently or at the level that they wanted to in terms of production. And the same group kind of broke it down and looked at the Hago subscale as to what was a negative factor, what was consistently keyed in as an issue for these patients. And when you look at those available, they're those higher level activities. So running as fast as you can, explosive movements, kicking, skating, etc. All those higher level athletic demands on their sport that they're just not at the level to be able to perform yet. And it's not just this one cohort. There are additional studies looking at this factor. And this was a study performed by Warner and colleagues again, and it found that 46% achieved the same sport at a lower performance level, 18% the same sport, the same performance. And at the end of the day, only 36.4% were satisfied with their post-op physical activity level. So while the return to sport numbers are pretty good, they're almost approaching 90% when you look at it as a whole. We aren't necessarily getting these patients back to the same sport at their same performance level. And it very much depends on the sport that they play. So this was a really interesting study by Christian and colleagues where they broke it down based on what professional sport league these individuals were playing in. At the end of the day, when they looked at the entire cluster, almost 90% returned to sport. When you look at the change in games played, so the red bar is one season before surgery versus the average of the season 2 and 3 after they had surgery. And the blue bar is one season before surgery versus one season after. So it's just looking at a comparison of where they were before surgery to where they were after surgery. And when you look at all the negative numbers, it very much varies depending on the sport that they play. So for professional athletes who play in the NHL, there was a drastic decrease in the number of games that they played. When we look at the MLB and the NBA and the NFL, while there were decreases, it wasn't to the same level. And they did normalize this data based on the length of seasons. So obviously there are 82 games in an NHL season versus 16 in an NFL season, but they normalized it representative of what these athletes go through. And then when we look at the change in performance, we see the same type of trend. So once again, 90% return to sport. But when we look at the NHL, there was a -36 and -37. So this is derived based on a formula that looked at pertinent statistics for these athletes. So for hockey players, they would look at assists, goals, points, things like that, and then put it all into an equation that then normalized it to all the other sports. So it kind of gave you a decent perspective of how the performance was after they returned to sport. And once again, there was a significant decrease once they returned after hip arthroscopy. And it's not just athletes. So this was another study performed by Riemann and colleagues. And at the end of the day, 75% of military personnel returned to duty, but only 47% returned without limitations. So this once again speaks to the fact that we're returning these individuals back to what they want to do and what they love doing, but there is a limitation at the end of the day, and it's a pretty substantial one. So at the end of the day, we have to take all this into consideration. We have to understand the limitations based on what these patients should expect to achieve. And all this should be in the back of our minds as we're advising patients whether surgery is worthwhile, whether it's worth it to have that consultation, and to set expectations, to let them know and understand that there might be some limitations down the road, and to understand how to best progress their program in order to get them back to that sport. And now what we're going to look at is what factors could aid us in understanding when a patient is ready to return to that full participation in sport. So when I determine return to sport, I tend to try to use all the factors available to me. And this is the START framework that kind of breaks it into a couple different steps. So step one is looking at health status. So that is looking at their psychological state, their performance on functional tests, pertinent imaging, medical-based and performance-based measures. And then once evaluating those factors, we then drop down to step two, where we evaluate these kind of risk modifiers. So what type of sport does this individual play? Are they performing in a impingement-heavy sport? Like, are they an ice hockey goaltender? That is going to modify our determination of whether they return to sport. What competitive level are they at? Are we able to protect the area that isn't necessarily pertinent to FAI, but if it was somebody that had a substantial contusion or something like that, it would aid in our ability to move them further down the road. So once we evaluate all these different important factors, we then get to decision modification. So these are the factors that aren't necessarily in our control, and they're factors that are more representative of the patient. So what time of the season is it? Are they coming up on the playoffs? Is it the off season? Is their team already out of the playoffs? All of these kind of factors will determine whether or not it's worth it to push this patient or this athlete back to their sport. And then there are other factors that can kind of modify our decision as well. So are there external factors or external pressures from the coach, the athlete's family? Are there financial factors? Are they not making any money during this time where they are on injured reserve? All these can be factors when determining when this patient's ready to return to sport. But today what we're going to focus on is that step one, or that evaluation of health status. So we're going to primarily look at the impact of previous injury. We're going to go through some functional tests, and we'll also talk a little bit about psychological readiness. And when I look at previous injury, it's important to recognize that of all the risk factors available in terms of hip and groin pain, the presence of a previous hip and groin injury is the highest indicator. And that's been found from several systematic reviews. This one performed by Ryan and colleagues that was then confirmed by Whitaker and colleagues in 2015. The odds ratios range from 2.6 to 7.3, so a pretty substantial increase in risk when there was a previous hip or groin injury. And then Langout and colleagues found a history of more than one previous groin injury was associated with current severe groin symptoms. And general injury sustained in the previous season was a risk factor for groin injury down the road. So understanding that previous injury does make the risk of future injury higher. So taking all this into consideration and making sure that our patients are well aware that they have to maintain their focus on their recovery and on their continued maintenance of this type of injury. And then finally, we're going to get into some functional tests. So today we're going to primarily look at hip-specific tests for sure, but we're going to break it into small chunks. So the first few tests will be your clinic-based tests. So this is where we're going to look at range of motion, strength, things of that nature. And then we'll move on to weight-bearing tests and to more functional hopping tests. So we kind of use it as a progression of that determining of return to sport. And we're going to start with the bent knee fallout test. So this is more or less a modification of the FAI position. And it's a combination of hip flexion, abduction, external rotation. And they found that a difference from side to side of more than 3.6 centimeters, so 4-ish centimeters, showed to identify those with hip and groin pain. So it can be something that's used to identify those range of motion deficits from side to side and identify future risk of groin pain for this individual. And there was one study looking at this specific test and its impact, or the impact of cam deformities or morphology on range of motion. And they found that there was a difference between those with and without a cam morphology, but it didn't necessarily approach statistical significance. But when you look at the numbers, there was about a 3 centimeter difference between the involved, or those with cam deformities, and those without. So it does give us some information as to how that type of morphology can impact the range of motion. And then when we move away from range of motion, we look at a simple clinic or field-based test to assess the tolerance of loading of the adductor and groin region. We come down to the Copenhagen 5-second squeeze test. So this is a really simple test that can be performed on the field. It can be performed in the clinic and could give us some information as to the tolerance of loading of that area. And what Thorberg and colleagues is they broke it into different sections. So a green light is they are able to maximally contract into the clinician's forearm, and they only experience 0 to 10 or 0 to 2 out of 10 pain. We then break it up into 3 to 5 and 6 to 10. And what they tried to do from here is to derive the function and the health of the hip and groin based on these factors. And they were able to do this. So this was a study of almost 700 athletes, and they found that increased groin pain intensity was correlated significantly with lower scores on the HAGOS, and especially when they broke it into those different chunks. And this study was not a study by itself. It was then later replicated by Warner and colleagues, where they did the same thing. They performed this in a little over 300 ice hockey players at the professional level. And they looked at how these different subsets then correlated with the sporting function based on the HAGOS sports subscale and the ability to produce force in terms of their adductor strength. And what they found was that when you look at the green versus yellow versus red, there was a significant difference as you move down the road in terms of their function and in terms of their ability to produce force. So this makes it a simple, easy to use clinical based test. And now when we move away from those clinic based tests and we move into more higher level or more functional tests, we look at what we have available to us in terms of POP tests. So POP tests are very common in the ACL literature. They're mostly performed straight ahead, and they're not necessarily performed in a medial or lateral direction. But Kivlin and colleagues wanted to look more specifically at the hip and groin, and they were trying to determine whether some of these lateral tests would be able to differentiate between the uninvolved and involved side and dancers with hip pain. This wasn't specific to FAI, or at least this study wasn't, but it was just female dancers who had hip and groin pain, and they tried to find if there was a difference between sides. So they did find that during the medial triple hop test, which there will be a picture of in a slide coming up here, there was about an 18 centimeter difference between the involved and uninvolved side. Unfortunately, when we look at the lateral hop test, there wasn't a significant difference. There was only about a 4 centimeter difference from side to side. But later, when we look at those with FAI and those that are deemed healthy, and take into consideration this is a pretty small cohort of patients, they did find a statistical significance between those that were healthy and those with FAI for both the medial and lateral triple hop. And there's a pretty substantial difference between the two. So this gives us some weight into knowing that hip function or hip pain may modify the success of our ability to perform these tests. and gives us an ability to test the tolerance of loading through the hip and groin region as we're determining return to sport. And there were a few additional studies that have looked at this. So this was a cross-sectional comparison of subjective and objective measures for those with hip and groin pain after hip arthroscopy. About 6 to 10 months after surgery, they evaluated those that had hip arthroscopy versus those that have not and would be deemed as healthy or unaffected in the groin region. And while these numbers didn't achieve a statistical significance, the p-values did not achieve what they needed to. If you look at the mean difference between the hip arthroscopy and the control group, there was a 24 centimeter difference between the two groups and a 35 centimeter difference between the two groups when we were looking at the medial and lateral triple hop in this cohort of patients. So there was a pretty decent chunk of difference between the two. However, when we looked at the operated versus non-operated hip, there was almost no difference between the two. So it gives us the ability to differentiate potentially between those with and without a history of a hip arthroscopy, but it doesn't give us a huge amount of information when determining whether or not their hip is equal to the other side. So these tests give us some information, but not to the same extent that maybe the hop tests do for ACL return to sport. And there are a few more field-based or more tests of fitness that I tend to use with these patients as well. So this is the 110-degree change of direction test. It was used in a few studies to derive biomechanical changes for those with athletic groin pain versus those without. It hasn't been used in terms of return to sport determination or anything of that nature, but it is a good test to determine how well they can quickly change direction and how well they can tolerate that change of direction. I do tend to record this and make sure that I understand how they move and identify anything that may be contributing to their pain. I then compare it from side to side. So I'll have them go from the right to the left and the left to the right. So they'll be cutting off of the other leg so that we can compare times from side to side, which can either give us information in terms of their hesitancy to cut off of that side or the strength and power that they can produce through that side. So it kind of gives us a decent snapshot. While it's a clinic-based test and there's no reaction to a stimulus, it gives us a snapshot into their ability to perform that cutting maneuver. And then finally, we come down to the shuttle test. So the shuttle test hasn't necessarily been looked at in the hip and groin literature, but based on the way it's oriented with the lateral movement and the change of direction for the athletes that I tend to work with, that this gives us a good indication of how well they can cut off of that leg, how well they tolerate it, and what the difference is from side to side. So all this gives us a cluster of information to determine their functional readiness to return to sport. And when we're doing especially those end stage functional tests, what we need to see is that they can tolerate the movement. So I'll use a similar scale as was performed in the Copenhagen 5-second squeeze, and I'll try to break into small chunks. So what I really want to see in order to return to full sport participation is the ability to perform these higher level type of tasks with a pain level that is around 0 to 2 out of 10. So trying to make sure that they have that tolerance for movement. And finally, we have to take into consideration that these tests aren't performed in the ACL literature, even though we know that there is a pretty significant change in risk of re-injury when these tests are passed. And taking that into consideration, we have to devise and better research these tests to see if there are similar findings in the hip and groin region. But unfortunately, at this point, we haven't necessarily gotten to that point. The hip is pretty far behind ACL reconstruction and even shoulder surgeries in terms of understanding what the outcomes are and what we can do to improve them. But what we do need to do is try to derive what these tests can offer us. And we haven't quite gotten to that point yet. But we have to think about what the most important factor is in returning to sport. And when we look at the ACL literature, it tends to be fear of re-injury. And when we look at that ACL literature, fear of re-injury was the most common reason cited for reduction in or cessation of sports participation. Athletes with low level of fear of re-injury had the best knee outcome after injury. And when we continue to look down the scale, factors associated with function after ACL reconstruction indicated that a combination of pain intensity, quad index, and the Tampa scale kinesiophobia all correlated with improved function. So while this is all looking at the ACL literature, it does extrapolate to the hip because these are athletes. Athletes need to be able to trust their joint. They need to be able to trust that they can perform the tasks that they need to. When they don't have that ability or they don't have that trust in themselves, it's very easy to go down the route of not returning to sport. And when we look at the qualitative coping strategies of those that do return and those that don't return to sport, this was a small study looking at those after hip arthroscopy and individuals that returned to sport versus those that didn't. And when we look at the bottom, when we look at the maladaptive mechanisms, these are individuals that are using venting strategies. They're blaming themselves. They're having behavioral disengagement. So they're distancing themselves from their sport. They're distancing themselves from their teammates and all those factors that go into their psychological well-being and returning to sport. So this doesn't necessarily give us definitive information as to who does and who doesn't return to sport because it's a very small study with a very small number of individuals that noted having maladaptive mechanisms. But those all come into play when we're determining the psychological readiness of these athletes. And then when we continue to look at what we have available to us in terms of determining psychological readiness, we come down to this excellent hip return to sport after injury scale. And it looks at various different things from emotions to confidence and to their risk or what they perceive their risk to be. So it asks them these simple questions. So are you nervous about playing your sport? Are you fearful of re-injuring your hip by playing your sport? And finally, do they think that they are at a higher risk to re-injure their hip when they get back to their sport? So all these factors are rolled into this questionnaire that gives us a psychological snapshot of where they think they are. And when we look at the impact of this scale on their performance or on their self-reported activity, the higher they scored on this scale, the more likely they were to return to the same sport at the same level. So that just kind of goes into understanding the psychological impact of return to sport. And then when we looked at their perceived change, they broke into whether this athlete felt that they are better after surgery, whether there was a small or no change, or whether they felt like they got worse. And when we look at that hip return to sports scale, the higher you did on that scale, the more likely you were to be in that better group. So understanding that return to sport is a function of their ability to tolerate load through the hip and groin, their ability to control their hip during functional tasks, and their tolerance for performing sport-specific movements are all huge factors in determining return to sport, in addition to their psychological outlook or how well they trust their hip and groin. You have to fall all this into a cluster of different tests, as I have listed here, and these are the criteria that I tend to use. And while limb symmetry index isn't necessarily derived based on the studies that have been performed, that's kind of my minimum threshold for getting these athletes back to sport. But the main thing is whether they can tolerate the sport at hand. So when we're in the clinic, you have to try to modify things in such a way to give them that same stimulus, make sure that we load these patients, make sure they get comfortable putting stress through their hip and groin, make sure they are comfortable performing high-level activities, improving the rate of force development. All of these different factors go into determining return to sport in addition to these tests that I try to outlay for them. And that's all I have for you guys for today. So a brief kind of synopsis of the return to sport criteria that I try to use in clinical practice. And what I really want people to get out of this is that in order to return these individuals to sport, you have to test them, you have to stress them, you have to load them, and you have to make sure that they're doing things that simulate their sport, and then gradually give them the stimulus that is representative of their sport, and gradually get them back to doing their sporting activity over time. Thank you.
Thank you, John. Like I said, that's really good information. That was a lot, but you did a really good job of condensing that in. I really like how you summed
I did my best.
Yeah, but I do like the cluster at the end, and that's something that I'm going to kind of bring up in my talk too after I saw your cluster. At this point, can you go ahead and go into participants and make me host again so I can share my screen? Thank you. All right, thank you very much.
All right, good.
All right, so now, let me get my PowerPoint up. All right, can you guys see my slides?
Yep.
All right, let me move this out of the way. So again, thanks, John, for going over that. Now I'll kind of bring it into the case I had talked about. But as a reminder, I'm going to go, we went over this last time, but a quick history was this was a high school quarterback and pitcher. His pain started in November, but he was referred to me in December, end of December. Had typical symptoms of FAI syndrome, so that's what he was diagnosed with. We tried conservative rehab for about 5 weeks, and during this time, from the start, we told his primary care and his surgeon, and so he did get 5 weeks of physical therapy, but he didn't get better, so we all decided that surgery might be the best option. Post-operatively, like Dr. Raymond had mentioned in his studies, that there's not really a good common agreed on protocol, but the protocol we used was from Gunderson. Just to note too, my last lecture last time I put the year as 2019. This was 2018, so it's going to make more sense as I talk about timeline. But it was basically just getting past range of motion back, pain management in the first phase. Phase 2 was a lot of active range of motion stuff, getting full range of motion, exposing him back to squatting positions. And then phase 3 was getting him back to resistance training, introduction to impact, and then eventual return to sport. And as you can see here, the protocol that we had was they're allowed to return to run at 3 months with PT and MD approval based on how they do with the screening. So at 3 weeks, he was doing really well. Usually anytime I test the lower extremity, I kind of have a pre-screen to their actual return to run screening to see if they're comfortable with it. I did squatting. I did single leg balance with 60 degrees knee flexion. I did single leg squatting, double leg hopping, and then single leg hopping. Last, I did forward step down, making sure they have good movement and no pain with any of that. Dr. Lewis and her colleagues in 2018 published a paper looking at the kinematics during a forward step down with patients that had FAI syndrome but did not go through surgery yet. The only kinematic difference they found was there was more anterior pelvic tilt in the group that had FAI syndrome. One thing I thought about was you would think they'd have a posterior pelvic tilt to avoid the pain, but maybe they had that irritation because they couldn't get out of that position. So when I screened them before running, I just see if I ask them to get into a more neutral or posterior pelvic tilt position, that they can do that. Next, I went through Blaze Williams. He's got a really slick return to run screen that's really easy to administer. So the first part of it was, it's 5 different tests and you get 1 minute rest between. But during the test, you get no break. So the first one was a hopping test. So they stand against the wall. You could put a little Post-it or tape about 4 inches above their hands, and they're going to constantly jump at that position. that you're going to put a metronome on at 160 beats per minute, and then you're going to make sure that their heels never touch the ground as they're hopping. They can keep the cadence, and that their knees never touch, so there's no kind of dynamic valgus. It's a pass or fail test. The second portion of it is a plank. So again, they're going to rest a minute, and they're going straight to the plank, looking for a typical good form. He said that if they move any part of the body, then that's a fail. So you're going to make sure they know that they can't even move their head. Next is a kind of like a single leg squat. For this one, I think the criteria was about 30 to 40 degrees of a knee flexion squat. What I'll have them do is I'll put a high-low table to that height, and I'll have them do a sit to stand. And same thing, they want to go 30 seconds each leg with no breaks. You want to make sure there's no dynamic knee valgus, and you want to make sure they can keep that 160 beats per minute tempo. The next one after that is going to be a step up test. This is about 8 to 10 inches. Same thing, you're keeping that 160 beats per minute tempo, and then you're making sure they have good form. He, as well as I, like to do it against the wall just because it keeps their trunk upright. And the last one is with a ball, you're going to do a wall sit. Again, they're going to have just 1 minute rest between all these. You're going to be in a good position, make sure it's 90 degrees. I'd probably have that person sit a little bit lower. And I don't think their hands can be on their hips too, but they're going to hold that for a full minute. And then those are all going to be pass or fail. So when I tested this patient, he failed his hopping because he couldn't keep up with the cadence, but he passed everything else except for a wall sit. The wall sit, I think in the last 10 seconds, he actually just kind of fell from fatigue. So he failed on that too. Dr. Williams says that 3 out of 5 is actually passing. He did, I think it's still unpublished at this point. He would like 5 out of 5. I think he has more data that if he said if he analyzed it, probably 5 out of 5. But as of right now, what he showed us was that 3 out of 5 of these screening tests are good enough to pass the test. So at that point, I allowed him to do interval jogging program. The one at Gunderson we had was the first week was going to be 1 minute jog and then 5 minutes walk 5 times every other day, 3 days a week, with the 4th day being optional. And then the next week, I think it goes up to 2 minutes of jogging and then 4 minutes walking, stepwise progression like that. As far as interval throwing, I think a lot of people might say it's pretty aggressive, and I could definitely agree with that argument. But in my eyes, if he's just throwing 45 feet, he's really not getting into that internal rotation of his lead hip, and he's more or less just tossing it, not really pitching at all. So I felt comfortable with him. Also, thinking about timeline, we did want him to get to play some kind of travel ball. So we want to get his arm capacity up. So I want to start him in some extent there. And obviously, if you have those, some people want their athletes to sit down and toss, but if you think about it, all that torque is just coming from their shoulder if you have them sit. So I thought it was okay for him to start an interval throwing program at that point, although the progressions were accelerated. Also around this time, we cleared him to do a 6 a.m. strength conditioning workout with his school. His high school is really good. They had a program where they had different hours where different sports would come. It wasn't very sport specific. It was general movement, general conditioning, then weightlifting together. And I went there for that, both just to help out the coach, but also to monitor any athletes that need modifications or anything like that. And he actually got through it fine. He obviously didn't do 100% of the reps, nor did he go full effort on everything, but most of the lifts he did well too. 2 weeks later, my co-resident Danny Larson, he did a throwing analysis on him, and this athlete did not do one off a mound. He just did flat ground. So in the windup, we didn't find anything significant that would affect his hip. Early cocking, if you can see on that where it says frequent biomechanical errors, if you look at the top right image on that lead foot, so we would consider that an error where it's a little too open. And his was at the 12 o'clock angle. Usually you want it pointed a little bit towards third base. So we figured maybe he's opening it up because he went at the end of his follow through, that's going to avoid any kind of like irritation to it. But we really didn't see a baseline of his pitching form, so we couldn't really tell. But that was just one observation that Danny made. Late cocking, acceleration were unremarkable. The main thing we want to look at was follow through, and the trail leg tended to cross over the midline, which you can imagine that's going to have some internal rotation on that lead leg, which was a surgical leg. Another thing that was interesting too was when he would cross over and then he would hop up from it. And we asked him, was he doing that because he avoided pain? And he said he didn't know. That's just he felt that it was what he always did, and it was just something goofy about him. So we assumed that wasn't to avoid any kind of irritation to that hip joint after the surgery. So 2 weeks later, he progressed through his interval throwing program. And then by this time, he was starting long toss, but we also wanted to do return to sports testing. This was around the time I was going to leave, so I did want to see some kind of initial testing from him. At the 3-month mark, the physician cleared him to run, but also the surgeon said in his notes, CPT for clearance. So at that point, he felt comfortable with our judgment on when he was cleared. So in my eyes, the protocol calls for about 4 to 6 full months for return to sport. So again, I think I was really pushing it with this testing and allowing him. The problem is if you test an athlete and they pass all of it, they're going to think they can do whatever they want. So that's something to consider. But given how well he was doing and how well he was doing through his strength conditioning, I still felt it was appropriate. As you can see here for his, I did handheld dynamometer testing. It was not belt fixed, but you could see these values are good. I would still say overall, his limb symmetry index more realistically was probably 90 to 100%. Senacor in 2017 found that for the quads at least, it underestimates it. So if you get above 100%, it's more equivalent to using a Biodex and getting 100% LSI or 90% LSI. So these values are very high, but I think realistically, because it wasn't belt fixed either and it was with a handheld, I think it's more likely that he was 90 to 100% equal. And percentage-wise, what I look for is in both in Hallberg and Frake, they looked at these handheld dynamometer values too, and they found that people who were scheduled for surgery but did not have surgery for this yet had a 10% difference side to side on most of these. Hallberg just looked at external rotation in kind of like a clamshell position, which is belt fixed. And then Frake used no belt fixation in all these planes, and he found that there was a difference of about, I think it was like 7 to 11% difference side to side on those who had surgery and those who did not. Or actually, no, those did not have surgery yet. They just had symptoms as well. So in my eyes, it tells me within 10% is going to be good, but I think ideally want them at 100%. Next one is we did functional testing. So double leg hop test, we use allometric scaling. So the measure I'm looking for that is good mechanics overall, but also that they can meet 96% of their height, which he did meet there. And then for a single leg hop test, he was equal with 97%, but the quality was good too. So he was doing good with both knee flexion and no significant dynamic knee valgus that was different side to side that I saw. For triple crossover hop test, he was unsuccessful with both legs. So we did a warm up, we did manual muscle testing, we did all these hop tests, we did isokinetics, which I'm about to share, and then we did this. So this was purely from fatigue, and we gave him a lot of amount of trials. So and it kind of makes me feel better that I didn't hold too much weight, because as John mentioned, it didn't seem to affect much of the decision making of return to sport for him. But that just told me, one, he needs to work on conditioning overall and then dynamic balance. But I still felt comfortable even if we didn't get values there. I did not do a Y balance test. Honestly, I can tell you, I don't know why. I think when I took John's course, he mentioned that it was a 6-inch difference that they're looking for posterior medial and posterior lateral. But I did not test that. And it's not in John's cluster, so I feel a little better again too. Next up, so I did isokinetics 1 because we came from Gunderson, so we're very biased towards isokinetics. That's where George Davies was from, and he has a heavy influence there. But also I went to CSM and I saw a talk by Stephanie DeStassi from Ohio State, and she had it was like a dancer who had hip FAI for years that did not get better, but after some rehab, they decided to go test the biokinetics, and she said it was worth it for certain athletes. Because I was returning him within 4 months, I thought it was good to do basically everything I could to really cover my butt, really. So as you can see here, both at all speeds, he hit the values that we'd like to usually see him at, both for peak torque and peak torque to body weight. So outcomes wise, subjectively, I just talked to him on the phone about 2 weeks ago. He said, I'm confident in everything athletic I do, but I can still feel deficits compared to my right leg. Yes, he used the words deficits, mainly with lifting. I didn't expect it to take this long to improve. I can deadlift again with no issues, which I could not do before. Squatting deep still feels weird, but more of weakness than the same pain. So overall, he's doing well, but he just needs to strengthen a little bit more. But he doesn't quite feel 100% yet. Speaking on that, I asked 0 to 100%, how good does your hip feel? And he rated at 90%. Having him take the Hagos, as you can see here, good values. I'd like his quality of life to be a little bit higher. But overall, I think this is on the higher end based on the 1 year and 5 year outcome studies we looked at last week. So comparatively, I think he's doing really good. Fear-wise, Dan Lorenz posted that article that you talked about, John, but I couldn't remember it, so I couldn't have him fill it out. So really, I just asked him, "Are you scared?" And he said, "I don't have any fear about re-injuring it, and I feel like I couldn't even hurt it again if I tried." That just made me smile because I'm glad he's confident, but it always makes you worry about athletes who have that kind of mentality. But I'm happy for him. Performance-wise, we did let him play travel ball, but I only let him pinch hit. I didn't let him do any kind of other field work. Hindsight, he probably could have, honestly, but I think 4 months was really aggressive, and I would have liked to slowly progress a bit more. Really unfortunate, too, because his senior year was lost. So I mean, we can't predict the future, but it would have been nice for him to play his junior year to an extent. But his main focus is actually football, and he knew that if he had to trade one season for the other, he'd gladly trade baseball away. So for football, we didn't do any performance testing. I didn't want him to go too much high effort during that 3 to 4 month period with this coach. But just looking at his follow-up season, as you can see here, his throwing stats were comparable, even with less games. But his rushing stats were low. So I thought maybe it was due to injury. Maybe it was him. Maybe the coach was protecting him. But when I talked to the coach said it was really because their starting running back was uninjured and was back again, and that the injury played no influence in the way they called plays or the way he participated. So he was successful, and then he'll be going on to Division III football, which he's pretty happy about. So in summary, 14 total official PT visits over 4 months. It's a little misleading because I did see him in the training room a lot. So I'd say 14 total official PT visits of one-on-one time, but over I'd say probably 3 to 4 times that amount of actual prescribing exercise for him there. I think he had a good outcome overall, especially at a 2-year mark. It was challenging for this case because of all the timeline constraints and his positions that we had. So trying to get him to play for the baseball season and his position as a pitcher, considering summer football conditioning and position of quarterback. Right after the testing, he left to Omaha, Nebraska for a 2-week vacation. So we weren't sure about the follow-up he'd have after. And we gave him the number to my mentors at Gunderson in case he needed to come back or wanted to retest anything. And again, from a liability standpoint, I think we did let him off sooner than most people would agree. But I think hindsight, I would have tested everything that John mentioned that he would do, but at least I have objective data, and I think it's still more than most PTs do, and it gave me a good decision making. So overall, I think it was good that we took objective measures overall in the case. From the start, there was shared decision making between him, his mom, me, the athletic trainer, primary care, and surgeon. What I could have done better was I probably could have sequenced all the testing better. I definitely think I was rushing the timeline given all the considerations. And again, the selection of tests, I would have gone with more of what was more evidence-based. I think in my head and a lot of others probably, we just go to the traditional ACL testing because that's all we know. But I think I would have been more specific to the hip literature. So these are my references. Go Deeks as usual. Here's a normative data. I sent this slide out, but this is normative data from one of the studies that I shared in case anyone wanted it for both the modified star excursion balance and hip strength manual muscle testing. And from then we can go into discussion. So I'm gonna look at if there's any kind of, Ryan, is there anything in the chat menu right now that anyone brought up?
No, not right now.
Okay. Hold on, I think Merritt just texted me something. All right, maybe Merritt can help with this, or some other baseball guys. But how soon can someone begin throwing if their lead leg had this surgery? What are your guys' thoughts? I asked Lenny Macrina, and he said 4 months was a good time to start interval throwing.
I would say it depends on how they're doing, and your athlete is at the time that you're doing testing was doing fantastic. So usually that 3 to 5 month mark is where I would start to introduce a return to throwing program. And based on all the data that you had, it was definitely within that wheelhouse.
Thanks, John.
Yeah, I think just having good eccentric capacity of the ankles, the knees, the hips, and trying to measure that, I think being able to do like some type of split squat with a significant amount of body weight and being able to tolerate that well through like velocity and repetitively, I think that would be something I'd look for specifically for a pitcher.
Yeah, Vien, I agree with a lot of the tests you did. I think that one thing, range of motion, getting in and out of that hip and being able to absorb force in that hip, especially with throwing. I'm in the same boat. I'd probably say anywhere in that 4 month range. Starting throwing can be pretty light too. Some things we do even is they throw without even a glove in their hand. Just not having a glove, it doesn't give them the mentality that they need to throw hard or anything like that. Getting back to a mound is a whole nother conversation, and that's just going to be totally different with them trying to get them to actually load into their hip through, especially with a lead leg injury. So that's the one thing I would say is mound is totally different than just starting the begin to throwing program.
Thanks, Mary. And we had a mound, so I'm kind of glad that we didn't use it. Just hindsight now, so thanks for that. All right. Getting back to the questions.
Hang on. So sorry. Liz jumped in and she's asking about the role of fatigue basically in return to sport testing. What are your kind of schools of thought on, in this case, would you have done anything differently or anything like that?
Fatigue wise, I mean, cardiovascular, I know he's going to be at a disadvantage. I mean, you can do so much cardio as you want, but they're always going to be a disadvantage getting back to their sport. As far as like a risk factor for injury, the ACL research shows that it's not convincing towards fatigue. And looking at the data on hamstring injuries, like we did when we were going the past 3 weeks, it showed that all the hamstrings injuries were equal in, I think it was Gaelic soccer, that there were equal amount of injuries per quarter rather than like the later ones. So I'm still not convinced that fatigue is something I would hang my hat on or make a decision to hold someone back. Overall, I don't think it affects my treatment though, because I'm still going to ramp up their conditioning overall. Because to perform well, they're going to need to not have fatigue. But as far as fatigue for injury, I don't know if that's going to go into my decision making on whether it can return or not. Obviously, you want to do gradual exposure to like pitching and all that. But yeah, I hope that answers the question.
Yeah, I think potentially if you're in an outpatient setting, maybe going through some type of fatigue protocol for like a 5-10 minute bout to repetitively fatigue them. That's what I did when I was in an outpatient setting, and then looking at their motions, making sure they're not completely falling apart. They still have good torso control, still decent foot displacement. Maybe run them through just like John was doing with that 110 degree cut to just make sure that their kinematics don't look significantly different. Other than that, I think if you have more access, I think you're just trying to gradually prepare them back to what those loads look like for their sport. So I think that's one way to even manage fatigue in the return to play setting, I'd say too.
Okay. And Ryan, for some reason I can't see the chat menu on it, so just feel free to interrupt me on it.
You can, yeah, we got nothing right now, so maybe next one.
All right. What tests do you guys all use for return to running? I know return to sports, I'm pretty sure everyone has like the hop test kind of stuff going on right now. I'm definitely going to add in the stuff John mentioned and talk about it and adding it in the next place I go to. But does anyone have a good assessment for return to running for it?
So Christopher Johnson puts out a ton of great content related to running. What I tend to use is, number one, making sure that they can control a single leg sit to stand or a single leg squat. Make sure they can tolerate jumping on one leg in all directions, forward, backward, side to side, straight up and down, diagonal, making sure they can tolerate that load. And then make sure that they can tolerate what I would consider fitness walking, or that awkward speed walk before you start jogging, for around 30 minutes or more. That way they kind of demonstrate that introductory tolerance for the load of running on the hip. And then I'd start to introduce that return to running program, starting with 3 short intervals from there.
Yeah, I like the multi-directional component. Never thought about that, so good deal. Anyone else have any other things that they like to do?
So I was just kind of thinking out loud. This is Daniel Karam from University of Delaware. I was just kind of thinking out loud in the fact that with the type of surgery it is, just the ability to go through and assess how much load can someone actually put through their hip joint. So I know there's some things with like the low back where you do almost like that isometric deadlift test, but something where you could do almost like a single leg isometric test to get some type of objective measure. I haven't seen that, and I haven't ever done that before, but just kind of looking at the surgery and kind of how when John was talking about these athletes' ability to accept load based on this type of surgery, I think that would be kind of interesting to know.
Thanks, Daniel. And if anyone doesn't understand the test he's talking about, it's kind of like a mid-thigh pull. You could use a barbell if you have that equipment, or you can attach a handheld dynamometer with handles to a board where you step on, and then you can go single leg or double leg as a monitoring tool as well. But that's a good test, Daniel. Thanks.
We utilize a couple different things in addition to some of the stuff that's already been mentioned. One of them is like a retro treadmill trot. So get the treadmill up at like a 10% incline or 10-degree incline, and they've got to be down in kind of a crouched position and up in like the 3.5 to 4.5 miles per hour, kind of depending on athlete size, and doing like a little bit of an interval there. The logic, and this hasn't been tested anywhere, it's just kind of an internal logic of working a little bit more fatigue. It's really going to be intense, really intense on the quads, and kind of making sure that they have the endurance. And then similar to what Daniel said about just like a strength test, we use like a rear foot elevated split squat, or like a Bulgarian squat, where they have to hold, we do 50% of their body weight. Most of the ground reaction force for running shows that it's closer into like the 2.5 to 3.5 times body weight. But we do 3 sets of 10 of that rear foot elevated split squat, where they're holding 50% of their body weight. Again, kind of round out the picture a little bit more, and are they able to take that load through the limb as a whole.
Thanks, Tim. It sounds like the theme is you could do it isotonically or isometrically, and different ranges too seems to be the theme for clearing someone to run. And as John mentioned, to do some kind of impact exposure. The next question was, what test do you use for a return to sport? Is everyone pretty much just doing the hop test, or was there anything that you guys do that me or John didn't mention? Yeah, and that's what I kind of figured, that we were all just doing the ACL testing.
In addition to that, with these patients, you have to get them under a barbell. You have to get them out under heavy load, and make sure that they can perform that single leg, double leg, because it changes the stress on the hip. So as a precursor to relying on those functional tests, you have to make sure that they can tolerate sport-specific load through the joint. So it's going to change drastically depending on the sport itself. But that's my precursor to going through some of those return to sport tests themselves.
Thanks, Sean. Maybe you can answer this, or Mike Raymond can. This is probably a hard question. But how soon is someone, I mean, obviously you want to do criteria if they can tolerate it too, but how soon, based on the surgery, can you start squatting below 90?
In my opinion, and based on what I've experienced, is very patient dependent. I'm obviously going to be relatively cautious early on, but in that 2 to 3 month range, if they can tolerate the load of going deep into a squat within reason, and we'll probably have to modify the way they squat a little bit, I'm comfortable with that. And it's all based on their tolerance. Once again, I want to keep the pain level relatively low, and that's 0 to 3 to 4 at the most, and make sure that the pain doesn't extend into the next day or worsen over the next 24 hours. And it's going to depend on whether they had a labral repair as well, that I'll maybe be a bit more cautious, but I'm not super conservative.
All right, thank you.
The only other test that I was thinking of is just the groin bar that's out now, just looking at isometric adduction, abduction holds. And just kind of going off your 90-degree question, how soon can we get these athletes into, like, you know, and maybe just a hockey population, John, just like how soon can you get them into like Olympic style lifts where you're just accepting that weight dynamically through the hips and the knees? Like how soon would you maybe prescribe that?
And once again, it's very dependent on how well that patient is progressing. And it'll kind of mimic where we are in terms of rowing, but maybe a bit more aggressive, somewhere in the 3 to 4 month range, usually closer to 3. But I have to make sure that they can handle slow, heavy resistance training, and then slowly introduce those more ballistic movements. So it's a very gradual process, but usually around that 3-month mark is where I start to introduce those types of movements.
Yeah, Ryan. And for that football player I had, when he started conditioning, which was around 3 months, we let him do power cleans where he caught at a high position and he didn't have any issues. And my thought too is I think it's even less impact than running because his feet are never really coming off the ground. I mean, maybe his heels are a bit. The other side of that too was you could start like push press and variations of it. I think there's some good strength conditioning research showing that push press, even though it looks like an upper body lift, you get the same improvements in hip power as a jump squat. So when they say no impact, that's my little loophole to get around it, where I'll just do that instead. So I'm pretty, with most people, I can introduce it pretty early that way.
No, I think I've had a little bit of similar thoughts, but I think that makes a lot of sense for getting through that kind of impact factor that you're talking about. I hope it holds up in a court of law someday, though, if it comes to that.
Yeah. Oh, I think Dan Lorenz is going to speak up. I'm excited.
No, I was going to say, remember, you don't have to do the catch phase. You could do pulls. You could do clean pulls, high pulls, snatch pulls. I mean, the catch phase freaks a lot of people out, and that's the phase that people get hurt the most if you look at the data on weightlifting injuries. So pull, and if you look at the force velocity profile on those lifts, it's even better than power cleans and hang cleans anyway. So pulls, you could do above knee stuff pretty darn early, especially with dumbbells.
Yeah, and there's 2 articles that came out in these past 2 years that I'll attach an email to send you guys regarding all those, both mid-thigh pull and push press. But going into you, Ryan, that groin bar, what tests do you suspect might be useful in serial testing and monitoring for team sports or athletes who have had this kind of injury? Is it worth it? And then what would you use?
Well, honestly, a simple one is just that Copenhagen 5-second squeeze test. It's a really good indicator of hip health, and the studies that have been performed have been excellently performed with large cohorts of patients. And it's been able to differentiate between those with and without groin pain and the function of their hip. So that's a really simple one that very much works in a field-based setting.
Thanks, John. John, so I got a question regarding that. So let's say they're usually at 0 and then mid-season they hit a 4 on that. You get a group of 4. What do you do when you see that data and trend?
So if it's just a one-off, it probably won't change much. But if it's consistent over a period, it maybe makes sense to take that athlete aside and focus on some hip-specific type of intervention. whether it be introducing low load, long duration isometrics, and then gradually increasing the strengthening of the adductor region, or taking a deeper look at the hip to see if there's something else going on that's producing that pain.
Okay. And then going back to the second point I had, actually thinking about it. So let's take away the football component, but think about the baseball. And also, I know softball is a way different sport too, but I had another athlete that also had a lead leg labral repair. How soon would you guys allow them to return to pitching? Both for softball, and then for one answer, and then baseball for the other answer. Would you wait till that 6-month timeline?
I would probably be more close to that 6-month timeline, with the caveat of I'd want them to go through a full return to throwing program prior to getting onto the mound. And once again, it depends that if they can tolerate it, 4 to 5 months is possible, but I'd say that's pushing it. The mound really does create a ton of stress on the hip and groin, so I'm more conservative at that, with that type of movement pattern. Similar to how I'd be more conservative with an ice hockey goaltender versus a forward or defenseman. It just changes my perception of the inherent risk.
Thanks, Sean.
I think this is an injury and a surgery that we don't know a lot about. We have a lot of good ideas, but not a lot of research. And I think this is one that if you try to rush it, it's almost always going to come back negatively. I don't think there are that many cases that if you try to push, let's say, the throwing program or the pitching a month or two early, that it's going to go well. Another test I like, I agree with John. I use the Copenhagen squeeze test a lot, both as an evaluation and just a day-to-day progress assessment. Another one I like is doing a single leg squat with a valve slide. So if you can use like the little valve slide disc on the turf, or just use a towel on a slide board, and you can measure the distance. If you do a single leg squat on the right and have the left leg go laterally and measure that distance, and then compare side to side. I think it's anecdotally, it's just one test that it's an exercise that we would do, but you would see early on that the difference side to side is pretty large. And as they progress, like that limb symmetry index improves.
Going back to the throwing question, I'd agree. It depends. I think it's just there's so much that goes into it with throwing, and then you got to make sure that their shoulder, elbow, everything else is okay at that time too, especially when you're getting them back onto a mound. A lot of it's just how can they handle that time under tension and that load. And so I think it's important as you kind of push them farther out, are they able to just handle that and tolerate different stressors to that hip? If it's the stride leg too, if they're limited in internal rotation, it's going to be hard for them on a follow through because they're not going to be able to accept that load as well. So there's a lot of other factors too on how limited they are with their range of motion and which leg is injured and how can they accept force into that hip and generate force out of the hip too.
Thanks, Merritt. And I really like your comment about the arm health of it, because I think a lot of people are so fixed on that hip that if they go too fast, you're going to have other secondary injuries, which I think, I mean, at least everyone in elite sports right now, we worry more about soft tissue injuries in other regions than their actual surgical site. That's a really good point. Going on the comments, I actually see it now. Let's see, Dan Loren said the FAST FP is an easy clinically based test to test fatigue. I will get that article for you guys to send out. He linked it there. Goodbye, Niles. Carrie said, may have missed this, but also consider clearing ankle, closed chain dorsiflexion, especially in lead lower extremity of the pitcher. Hey, Carrie, do you want to expand on that for us? If your mic works.
Can I say my mic doesn't work?
Yeah, I can't hear you. Never mind.
No, just I think, you know, it's probably just pointing out the obvious, but I think such a big factor, especially in those pitchers, throwers, overhead athletes, any athlete really, but just another link in the chain that is I think a pretty common precursor or a common issue with those folks, whether it be knee or hip related. So just making sure they have adequate closed chain dorsiflexion, especially in that involved leg or that lead leg, and especially in a pitcher.
Thanks, Carrie. And do you like the version with the digital goniometer, the wall test, or do you do the FMS version of the ankle clearing test?
I will typically do a wall test. Right. I think you can also just, so you can do that and quantitate it. Also just looking at overhead squat, single leg squat, it can be a pretty quick screen either way.
All right. Thank you, Carrie.
Sure.
Really quick, back to your point about softball versus baseball. I was just watching highlights of softball pitching because it's not something I'm readily familiar with. And it's interesting. It's like the lead leg, first of all, there's no mound in softball, so it's something to consider. It's not as much force coming down from that. And then the other thing is the lead leg, it's more just stiff. It's a quick stride out from the hip, and then it's just a slight knee bend. Not much ankle dorsiflexion, definitely not much hip. So I'd imagine it's still quite a bit of force. I'm just, I think they use their abductors as braking a little bit more so versus their knee eccentric motion. So it's interesting. It's definitely different, but I'm not sure if the timeline would be that much different from a baseball player.
Thanks, Ryan. My mentor at the time that teaches the pitching stuff, he found like 2 articles looking at softball form, and there wasn't much on it. I can't remember what he said, but there was one certain position of the softball pitching that he said was important, but I think that was more towards the trail leg. But going back to my case overall, do you guys think I should have given that athlete more time for conservative care? Or do you guys think I rushed that surgery a bit? That's what keeps me up at night still.
So I don't think that you made the wrong decision because it turned out really well for the patient. Like their Hago scores are fantastic. It sounds like he's functioning at a high level. I would say the 5 weeks is pretty low on the threshold for surgery, in my opinion. And a lot of the literature that's coming out is kind of looking at that 3 to 6 month mark in terms of conservative management. There's a recent systematic review by Kemp and colleagues that found a pretty significant increase in effect size of programs that are 3 months or more for conservative management of FAI. So that's usually my threshold. I tend to keep patients for a while before going down that route. But once again, when we look at that START framework, that can be used for decision-making in terms of surgery too. If this patient wants to get back to playing football relatively quickly and we're not making any progress, it's going to kind of increase our need for that surgery potentially. So it worked out perfectly for your patient. It sounds like he's functioning at a high level. I probably would have kept him a little bit longer, but that's neither here nor there.
Yeah, and I agree. Like, I like to keep people, I think all of us do, including surgeons, want to keep people conservatively for the most part. And I agree, the research that Destasi presented at CSM agreed with that too. That's what she showed. The hard part for me was, I think it was like the what if we get 3 months in and then he has surgery and now he's 3 months away from his summer conditioning. So I think that's the big factor, but that's why I keep questioning myself on whether I did. I mean, and I asked him, how do you feel about it all? And he said, typical high school answer, I'm cool with it, so, but just wanted other people's thoughts on that. But definitely one of my more aggressive cases that I've put thought into. Does anyone else have any major points they want to go over? Any questions? If not, next week we are at 8:30 again. We got good old Carl White. He was a former athletic trainer at Wake. He was a part of the CARE Consortium, which is a group that looks at NCAA concussions, just different aspects of it all with incidence return and outcomes with it. He was also at another school prior to that with one of the main researchers on the team, and our primary care physician at Wake is also a member of the CARE Consortium. So I'm going to try to find some good articles, and then really for him, he's going to do kind of a Q&A on what he's seen, the issues with the data analysis or during data collection, and give you guys an insight on that. So it won't really go into treatment of concussions too much, but it'll go over how we can better understand and study them later on. But again, thanks for everyone for always showing up. It's always a good crowd, always good discussion, and hope you enjoyed it.
Thanks for having me on, Vien. Appreciate it.
Thank you, John. Appreciate you.
Thanks for being here, John. Really appreciate it.
Of course. It's a pleasure. I love rambling about hip stuff.
There's no rambling.
All right. See you guys.
Yeah.
Have a good day. Stay safe, everybody.